class. Welcome to the last week of PGHE. This next session is going to be focusing on racism and health, which is one of the very important topics in global health equity, because racism is one of those biggest challenges that societies face. So the session is going to be led by Dr. Michelle Morse. She's an assistant professor at Harvard Medical School, but she's also a visiting faculty here at UPHE. She's the co-founder of EcoHealth, which is an NGO that inspires the next generation of healthcare professionals in Haiti, and has been very instrumental in building the hospital that's supported by PIH and making sure that the human resources for health are trained. She's now a policy fellow and a very enthusiastic global health equity advocate. And this session is going to be it was meant for not specific for this audience. It was meant for a conference, but the conversations that you will find in this recording are going to be very instrumental in understanding racism and health and how they interact and how they affect health equity. Enjoy her lecture.
Thank you so much for having me today. It's a real honor to get to present to the coordinated work of Beyond Flexner and the American Medical Association. I'm honored to talk about anti-racism at healthcare institutions and how far we can go. The three questions I'm going to explore during this brief presentation are: why is this an important moment for institutional change in healthcare? What are some examples of successes and challenges in anti-racist institutional change? And how far can we go? Perhaps the most important question. It's important to remember definitions, and language matters even more in health equity work. I'm going to be using the term health equity and health inequity rather than health disparities. Health disparities, based on my definitions, are differences, whereas health inequities and health equity are differences that are unjust, avoidable, unfair, and I want to make sure that that distinction is clear. I also want to use the definition of race that defines race as a social construct with no genetic or biological basis. Everyone in health and healthcare is really understanding the determinants of health in new ways, and this is an important moment for us to take that analysis to our work of making sure institutional change happens. Everything from biological on up to structural forces force and determine health outcomes. But what we know is that inequality creates worse health problems. And this is a great example and a very unfortunate example of the U.S. compared to other Western wealthy democracies. What you see here is that when you compare this index of social problems to the health outcomes and income inequality, the USA is clearly an outlier with both a very high level of income inequality and a very high level of health and social problems. If we blow this up to a global scale, we must always remember and bring in our analysis of global issues and the global history of colonialism and how it has shaped economic inequality and all of the other types of inequality that flow from economic inequality, such as health inequality. And when we bring that analysis to our own country here in the United States, we have to remind ourselves that in our 400-year history, we, at least for the most recent 13% of history, have been in the era of structural racism. And prior to that, prior to 1965, we're in the eras of chattel slavery and Jim Crow segregation. So it's only very recently that we have moved beyond slavery and Jim Crow segregation when you think about the long span of our country's history. And each of these three eras had corollaries in health about exactly what the health community thought about issues of racism and race and ethnicity. Even in our current era of structural racism, we have profound problems when it comes to our understanding of the lack of biological difference between races. That actually has massive impact on health outcomes And this study by Dr. Bailey and colleagues really demonstrates how important it is to remember that only the most recent 13% of history was beyond slavery and Jim Crow. And in this landmark paper about structural racism and health inequities in the United States, it's very easy to see how that legacy lives on in this very moment. And when we take that analysis to a local level, Boston is a great and unfortunate example of how current chronic disease hospitalization rates are actually linked directly to the same neighborhoods that experienced racial redlining in the 1930s, as evidenced by the smaller map with the red outline. Critical race theory can be really helpful in allowing us as health professionals and health workers to try to better understand why racism is so permanent and persistent in our society. I would guide you towards the interest convergence theory in particular, which helps us to also recognize, unfortunately, that racial justice and racial change in the past, as evidenced by Brown versus the Board of Education, was really not a result of a moral awakening amongst whites in this country, but was rather about a convergence of the interests of white male elites with racial change for a long series of reasons, and I would encourage all of you to delve more deeply into that theory. So what are some examples of successes and challenges in anti-racist institutional change? I'm going to share two examples from my own experiences at Brigham and Women's Hospital in Boston, Massachusetts. The first is around the evidence base for race-based practice in kidney function. Many of you are aware as clinicians that the MD-RD equation as well as the CKD-EPI equation, the more recent standard that's used also very widely across this country in our laboratories, both quote-unquote correct kidney function eGFR for race, specifically Black race, and Black race is the only race that this is corrected for. If you look back, which I do often, at the 1999 study that was published by Levy et al. That really defined this equation, what you'll see is actually that study only had 197 Black patients, and ethnicity and race in that study was assigned by study personnel without any explicit criteria, but probably by examination of skin color. In addition, that study in 1999 actually based the difference in kidney and eGFR for Black patients on a theory that Black patients have greater muscle mass than white patients. And the MD-RD study published in 1999 referenced 3 studies from the 1970s and 1990s with very small numbers of patients who these studies reportedly showed that Black patients had greater muscle mass. Again, they're small studies and they're very old. So what's the bottom line with eGFR? Well, the harm is definitively greater than the good. Black race being used as a proxy for muscle mass is completely inaccurate. Race actually itself was assigned by study personnel. So we have actually no idea what the study personnel were measuring in the 197 patients that they defined as quote-unquote Black. This equation also leaves much to be desired about guidance for what mixed race individuals should do, such as Barack Obama, who himself is of a mom who is white and a father who is considered Black. And so what should we do for Barack Obama's kidney function? Should it be corrected or not? It's unclear. So there are several concerns. And because of this, students all around the country are trying to change this practice. In fact, the University of Washington, Mass General Hospital, Brigham and Women's Hospital, and several others, including Beth Israel, which was the first institution to do this, and San Francisco General Hospital, have stopped using race correction of kidney function. Most recently, as a part of the work of Equal Health, my organization's campaign against racism, the Vanderbilt chapter of our campaign worked for 2 years with colleagues at Vanderbilt, including Dr. Wilkins, and are now also ending the practice at Vanderbilt. We also know that COVID has highlighted just how bad end-stage renal disease is. And what we know is that Black patients have a much higher rate of bad outcomes from chronic kidney disease, such as lower rates of referral to nephrolation for transplant and lower rates of transplantation, all of which could be worsened by the use of correction of Black race in the EGFR equation, and likely that is the case. Another example of institutional change that is consistent with anti-racism is our work on heart failure at Brigham and Women's Hospital. It's clear that heart failure outcomes are critically important at our hospital. Heart failure is one of the most common diagnoses in the hospital. What we found and what our residents observed, and resident ideas and concerns are really one of the major motivations for doing this study, is that residents noticed that there seemed to be more white patients on our cardiology service and more patients of color on our general medicine service with heart failure. So what we looked at is almost 10 years of data of patients with heart failure who self-referred to the emergency department and were admitted to our medicine service or to our specialty cardiology service. We looked at their race, and we looked at over 1,900 unique patients over this almost 10-year analysis. And what we found was that Black and Latinx patients were systematically less likely to be admitted to the specialty cardiology service when they were coming to the emergency room as self-referrals with symptoms of heart failure. And this was corrected for all of the typical things that you would correct for. We also found that women and patients over the age of 75 were systematically less likely to go to the specialty cardiology service. The reason this is important is because we look often at the inequities in heart failure outcomes, and we notice that Black and Latinx patients have higher rates of readmission for heart failure. But at our hospital, if those patients who are Black and Latinx were admitted to the cardiology service, which has cardiologists as well as additional wraparound services on discharge for heart failure patients, those patients actually have the same rate of readmission as white patients. So this suggests actually that this is an example of structural racism at our institution, because it is a disadvantage to Black and Latinx patients in the distribution of a resource, which is access to subspecialty care. And in fact, with that subspecialty care, there were no racial differences at all in readmission. A huge, huge discovery, and a very important one, and Brigham should be commended for its leadership in disclosing this and studying this as a single institution study. What has come from it is 3 projects funded by the Department of Medicine at our hospital to really understand and address this problem. Those 3 projects are looking at a survey to understand how triage is happening in the emergency department. It's a quality improvement project to also improve the quality of heart failure care on our general medicine service. And what we're working on right now is the third project, which is an intervention to actually fix this inequity. So the question remains, how far can we go? It is 100% crystal clear that correction of EGFR for Black race needs to end immediately based on the lack of scientific rigor in which that practice was initially started. It's also 100% crystal clear that the racial inequities in kidney disease and transplant in our country alone warrant elimination of this practice, because it is likely contributing towards those racial inequities. And it's also clear that heart failure subspecialty care needs to be accessible to all patients, and that Black and Latinx patients, as well as women and the elderly, must have access to that care. Those are examples of institutional change that have moved forward, but how far can we go? One of the ways that we tried to describe our institutional change process is through this article that was recently released in the New England Journal. But one of the many, many challenges of the continued work of anti-racism at academic medical centers and at healthcare institutions in general is that we must also look at the business practices and the policies that guide clinical care. These can be some of the most difficult policies to change in hospitals because they relate to payments and to the business practices, but they must be reexamined using an anti-racist lens if we ever hope to achieve health equity and racial justice. In addition, we must remember that our history can be a guide in some ways. Medicare itself, actually, payment for Medicare was withheld from facilities who violated Title VI of the Civil Rights Act, and that is what led to desegregation of our hospitals back in the 1960s. We should be revisiting what worked and what didn't work with that action. But more than anything else, if we intend to end racial inequities, achieve health equity, and demand racial justice at our institutions, we must recognize that several decades of race-neutral and colorblind policies have gotten us to this very point. And if we intend to change the racial wealth gap, which in turn contributes in many ways to the racial health gap, we have to consider non-race neutral policies, policies that are race explicit in healthcare institutions and beyond. One of the best examples of this is a recent preprint study that just came out that describes, actually, if we eliminated the racial wealth gap in our country, what would the impact be on SARS-CoV-19 transmission across the country. And this study found, actually, that there would be a 30 to 60% decrease in COVID transmission for the whole entire community if there were a restitutive remedy towards Black individuals who are descendants of slaves, specifically addressing the racial wealth gap. Unequal treatment, which came out in 2003, led us to a really powerful community and national conversation about inequities in healthcare. But now it's 2020 and we're in the same place. Much needs to change. And I think for us to continue to evaluate how far we can go in racial justice and health equity at healthcare institutions, we need to do much more work that's evidence-based about really addressing at its root the causes of structural racism and healthcare inequity.